All right, and we'll
try
all
again.
mute when we're not talking, right?
I think I heard her.
Are you able to hear me now?
Yes.
Yes. Perfect. Okay, now you can start, Alex.
Let's go. Okay, hello everybody. Thank you for being here. I'm Alexandru Mischie, cardiologist working at Montluçon, France. I have a huge honor today to co-moderate this webinar with Professor Annabelle Volgman from Rush College of Medicine. And we have the pleasure to present to you the webinar named The Best of ACC 2020. We had around between 500 and 600 subscribers. I think most of you will be here online. If not, you can review the webinar on our social media channels or on YouTube. So without further delaying the presentations, because we have very hot topics, I will give the word to Professor Annabelle Volgman, Professor of Medicine, Rush College of Medicine, and the immediate past chair of the American Heart Association Women in Cardiology. Hi, Annabelle. Thank you so much for being here.
Hi, Dr. Mischie. Thank you so much for inviting me again to moderate this great webinar. We are just very excited that we had an in-person meeting at ACC. We had a lot of fun and it was great to see everybody there. We missed you though, Alex, so we hope to see you at AHA in Chicago.
For sure.
But we have four distinguished speakers today, and we will go by prevention, ischemia, heart failure, and last but not least, arrhythmia trials that were presented at ACC 2022. So our first speaker, and I'm going to introduce them as they before they present. Our first speaker is Dr. Gina Lundberg, who is the clinical director of the Emory Women's Heart Center, and she is a preventive cardiologist. Dr. Lundberg is an associate professor of medicine at Emory University School of Medicine in Atlanta, Georgia, and the current chair of the Women in Cardiology Council. So welcome, Gina. She will be presenting the best of the prevention trials. Thank you.
Thank you, Annabelle and Alex. And yes, I'm here today as a preventive cardiologist representing the prevention section. There's several studies I want to go over with you, so they're going to be kind of quick and from the 30,000 foot view, but you can get online. There's some wonderful little like central illustrations that ACC is putting out to give you a synopsis of the studies. So first I'm going to start with higher coronary artery calcium burden associated with greater sudden cardiovascular death risk, regardless of ASCVD risk factors. And I'm a big fan of the coronary artery calcium score for identifying risk and risk stratification. And what this study from Alexandru Razavi showed is they used data from the CAC consortium, which is a multi-center observational cohort. There were over 66,000 patients that had coronary artery calcium scores between 1991 and 2010. So this is rather recent technology of how we're using it, not the oldest way. And they were for patients who did not have diagnosed coronary artery disease, but had cardiovascular risk factors. Calcium scores were identified as 0, 1 to 99, 100 to 399, 400 to 999, and then greater than 1,000. And they had, the average age was 54. So I tell a lot of my patients around 50 to get it. So clinically, this was useful. And there were 33% women and 11% were non-white. More than half the participants had a calcium score greater than 0. So this group with risk factors was rather high risk. And the scores went up to over 1,000. And what they found was as the score increased, the risk of sudden cardiac death did as well. So that those with a calcium score greater than 1,000 had an 85% increased risk of sudden cardiac death. So not only is calcium scoring useful for risk stratification and identifying how aggressive you should be with risk reduction, it's also associated with sudden cardiac death. Next, I wanted to tell you about Pac-Man AMI, and this was using alirocumab, also known as Praluent, and high-intensity statin therapy, reducing high-risk plaques, and this was post-MI. This was a non-infarct related arteries that they were looking at 52 weeks, and these were patients who had had an acute coronary syndrome with the culprit vessel being treated with stent. And what they found was at 52 weeks, the non-ischemic plaque burden had reduced by about 2.13% compared to 0.92% in the placebo group. Also, the fibrous cap had thickened at 62 micromillimeters compared to 33, suggesting that the early initiation of these drugs is important post-MI. It can be difficult because these drugs require prior authorization, and it doesn't always seem easy during the hospital admission, but that is a time of highest impact with the patient also. So maybe we should be considering these drugs at the time of MI and not later in their follow-up course. The study, the effect of inclisiran in patients with prior MI, post hoc pooled analysis from Orion 10 and Orion 11 was also presented. And what this showed was, again, prior MI, whether recent or greater than a year, showed benefits with aggressive risk reduction with lowering LDL through inclisiran injections twice yearly. And the percent change, whether recent or remote, was in the 48 to 55% reduction. So again, very powerful drugs for reducing plaque burden in non-culprit arteries. The Apollo study got a lot of attention, and that's using short interfering RNA, shows promise for reducing Lp(a) or lipoprotein A. So this study was by Steve Nissen, and this is this new class of drugs we've been hearing about for a few years, the short interfering RNA. And this drug is specifically identifying lowering Lp(a). This would be the first drug we actually have to lower it. And in this study, they were receiving 300 or 600 milligrams of SLN360 and drastic reductions. We saw 96 to 98% reduction in Lp(a) levels, in addition to LDL being reduced 20 to 25%. The only serious adverse event was some injection site irritation. So again, very promising study using short interfering RNA for Lp(a). Another study with semaglutide. This was once weekly high dose semaglutide on body weight and physical activity. And to sum it up, I would call this win-win. Patients lost weight and they became more physically active. Now, this was a study over about a half a year to 2 years. And so this was a slow progressive weight loss in these patients. It wasn't quick and immediate like our patients want, but using 1 milligram and the newly approved 2.4 milligram dosing, these patients had 6.6 kilograms of weight loss compared to 1.2 kilograms without it. And very important, became more physically active. And last is the fun article. Hopefully you've been hearing that coffee is good for us now, and as an avid coffee addict, I like this justification. So what they found was patients who had previously been told don't drink caffeine due to palpitations or arrhythmias were allowed to drink coffee. And what they found was even 1 cup per day was associated with long-term mortality improvements, and the sweet spot is 2 to 3 cups of coffee a day, which is what most Americans take in. I asked what happens if you have 10 cups of coffee a day, and there was no data available. So your coffee is safe, you can enjoy, and I hope you like this short wrap up of prevention studies at ACC 22.
Thank you so much. Thank you so much, Dr. Lundberg. Did you want to say something, Alex?
No, please go ahead, Annabelle.
Please ask your questions in the Q&A, and we will ask our speakers their specific questions at the end of the presentation. So our next speaker is Dr. Roxana Mehran, who is the Director of Interventional Cardiovascular Research and Clinical Trials at the Gina and Michael Wiener Cardiovascular Institute. She is a professor of medicine at the School of Medicine at Mount Sinai in New York, and she will be presenting ischemia and intervention trials. Thank you so much, Dr. Mehran.
Thank you, Dr. Volgman. I actually have some slides that I kind of put together quickly, and I know that Dr. Lundberg did a beautiful job presenting the this important study, the Pac-Man-MI study. I thought it was important to kind of think about it as a secondary prevention in our patients with an acute myocardial infarction. Before I begin, let me just tell you that to me, clinical trials are the core of how we build our guidelines and how we basically translate them into clinical practice. And I think some of the highlights from ACC are tremendously important. And I want to really thank you for putting this webinar together so that we could bring a snapshot of the science to the world and share it with all of our colleagues and bring them up to date. The Pac-Man-MI study I thought was tremendous. I was part of the complete trial, which is the complete revascularization in STEMI patients, showing a great benefit of revascularizing everything. But looking at this trial with the use of alirocumab, small numbers of patients, not really powered for an outcome, but rather looking at the non-culprit vessel regression, showing some really interesting mean change in percent atheroma volume, I believe is tremendous. I would love to see now this, and I know that there is a trial that is being designed, and I'm very, very happy to be a part of it. It's called Evolve MI, where alirocumab will be administered at the time of an acute myocardial infarction versus placebo for an outcome study, which I think would be very, very interesting. I wanted to talk while we were on the heart attacks about the Global Heart Attack Treatment Initiative that was also presented. This is over 4,000 patients. It's a 2-year report of a new project that has been put together by the Global Heart Attack Treatment Initiative, which is through the American College of Cardiology and our colleagues listed here, the Gaudi investigators, who have done an incredible job bringing all these nations together with a very, very good way of collecting prospective data in MI patients, acute MI patients. And what they showed us, although this was an interim report, is that even though they've just only begun in the last 2 years, they have made tremendous impact in some interesting and modest outcome differences in improving left ventricular ejection fraction, and even a change in the proportion of patients who are being discharged alive over time, which I think to me is incredibly intriguing, and looking forward to the follow-up and the larger and larger numbers of patients and nations who will come in to this Global Heart Attack Treatment Initiative to improve outcomes of patients across the globe with a STEMI. I think this was one of the very, very interesting studies, the safety and efficacy of an old drug, tranexamic acid, in patients who are undergoing non-cardiac surgery. This group, who have worked very, very hard on the POISE group, this is POISE 3, they have been working on non-cardiac surgery, looking at cardiovascular outcomes in non-cardiac surgery. And here, in 114 centers, 22 countries, TXA versus placebo at the start and the end of surgery. And they really had a wonderful inclusion of women, 44% women. They showed a very, very interesting and important outcome in the patients who received TXA compared to placebo in terms of their outcomes, which was significantly improved, a 13% reduction. The rates in terms of bleeding and the rates of cardiovascular outcomes were similar. Now, this is a not such a new drug, and when the audience was polled and the commentators on the panel were polled, many, especially cardiac surgeons, use this in their surgical suites, but actually many do not. And it seemed to me that this really has to be sort of part and parcel of what we do, a drug that helps reduce bleeding without changing ischemic events. Another myocardial infarction study, a very, very well done study looking at ischemic preconditioning with sodium thiosulfate. I get very upset because no matter what we do with ischemic preconditioning, we're not really getting a great result. But this was a beautifully well-conducted study in the Netherlands, 380 patients. They overpowered because their outcome was a cardiac MR looking at infarct size and recovery, myocardial recovery. Unfortunately, they did not meet the primary endpoint of improving infarct size, nor did they show any improvement in left ventricular ejection fraction or NT-proBNP levels at 4 months. I guess one of the big questions was that, were the infarcts large enough? Was there enough time? Because in the Netherlands, they're so great in taking care of that myocardial infarction that even in these 3 centers, they were so well versed and so fantastic in treating the patients that they were underpowered to show the difference. So unfortunately, they did not meet statistical significance, and this was a negative study. The other study is about how do we guide our percutaneous coronary interventions in patients with intermediate coronary stenosis. We're often thinking about physiology, or is it anatomic evaluation with intravascular ultrasound? And of course, very, very important study, 1,700 patients randomized to an FFR guided versus IBIS guided interventional strategy in patients with coronary stenosis. They found absolutely no difference in the 24-month, 2-year outcome of these patients. The difference here, though, was that the FFR group received less coronary stents, yet they had the exact same clinical events down the line. No difference in myocardial infarction, revascularization, no difference in quality of life SAQ scores. So really interesting to me. It seems like maybe a physiology based algorithm is probably better if you're going to be putting less stents in and get the same outcomes. But it's not to be sort of replaced, because you wonder, FFR is great in evaluation of what should be stented, but then once we stent, I think intravascular ultrasound is usually the way to go to get the optimal results. Although in the FFR guided here, they use post-stent FFR, and those patients seem to do completely fine out to 2 years. So to me, it's a very, very important study from our Korean colleagues. Then I want to talk to you about peripheral vascular intervention. This was a head-to-head randomized study of a really interesting balloon technology called Chocolate Touch. This chocolate balloon is almost like a pillow-like device that is designed to have less trauma to the vessel wall, coated with paclitaxel. This was compared head-to-head in femme-popliteal lesions to another drug-coated balloon that's paclitaxel-coated balloon Lutonix, and they looked at the 12-month evaluation of both non-inferiority for their efficacy and safety endpoints, and then superiority in terms of both. What they found is very, very interesting, that not only was the Chocolate Touch non-inferior to Lutonix, it was actually superior to the Lutonix group. So they met both of those, and the safety was not an issue at all. So it kind of opens up the question of, are these paclitaxel-eluting coated balloons safe to use? And as you know, there was some evaluation of the association of the paclitaxel-coated balloons with mortality. But when you look at this and you're seeing excellent results, you kind of think about maybe we need to reopen this important issue. I think there were also some featured science. I have a conflict. I was a co-author on the complete quality of life complete trial. As you all know, this is the largest clinical trial. We had up to 3 years SAQ. We were part of the quality of life subcommittee. Shamir Mehta presented this beautiful result showing that both residual angina and quality of life seemed to be better in the patients who had complete revascularization, as opposed to those. Both groups actually enjoyed the benefit of revascularization, but those with complete revascularization did have a better quality of life, less residual angina at follow-up. And I think is important to kind of note that the FFR Fame study, the Fame 3 study, which was FFR guided multivessel PCI versus CABG, as you know, this was negative in terms of improvement in the FFR PCI, but very important is the quality of life questionnaires. Down the line, they looked exactly the same between CABG and PCI, and in fact, the quality of life suggested that the regain of the functional status happened sooner after PCI compared to CABG, and no difference at 12 months. And last but not least, I think this is a really, really important area of future investigation with non-obstructive coronary disease and ischemia. These were the small numbers of patients, but still a first sort of a treatment modality for them to receive diltiazem or placebo. Unfortunately, this did not pan out for the primary endpoint in terms of treatment success of these patients who had microvascular or coronary artery spasm with ANOCA. But as you can see, there was no improvement, unfortunately, as you might have and would have loved to expect. But this really tells me that we need to do more work in this arena, especially as it pertains to women who present with non-obstructive coronary disease, ischemia, and even myocardial infarction. So that's a wrap for what I found to be interesting. And I thought that I would give it back to both of you for further evaluation. Thank you all.
Wow, thank you so much, Roxana. That was a whirlwind of studies. We were also busy at ACC, so this is really such a great summary of all the studies from the different fields. The next speaker will not speak about the ACC trials, but she will be speaking about even more important new guidelines for heart failure. So without further ado, it's Dr. Biykem Bozkurt, who is the vice chair for the 2022 AHA, ACC, HFSA guideline for the management of heart failure. She is the incoming editor-in-chief of JACC Heart Failure. She holds 2 chairs, the Texan Moncrief Chair and the Mary Gordon Kane Chair, and she is a professor and vice chair of medicine at Baylor College of Medicine, and she is the medical care line executive at the DeBakey VA Medical Center in Houston, Texas. Welcome, Biykem, and thank you so much for moving your national meeting to join us today. Thank you.
Thank you, Annabelle. It's a pleasure for me to present the 2022 American Heart Association, American College of Cardiology, and HFSA guidelines that were released last week. And I had the privilege of being the vice chair of these guidelines. In the new guidelines, we classify the ejection fraction very similar to the universal definition of heart failure as heart failure with reduced EF, mildly reduced EF with EF 41 to 49%, preserved EF with EF being equal to and or exceeding that of 50%, and also as improved EF with a baseline EF in the HFrEF range and a subsequent EF of over 40%. And please note that we specified elevated filling pressures, especially for patients with EF over 40%, including those with mildly reduced and preserved EF. And elevated filling pressures can be defined by non-invasive methods such as natriuretic peptide levels or non-invasive imaging, or by invasive hemodynamic measurement. The treatment of the symptomatic heart failure with reduced ejection fraction now includes 4 foundational classes of therapies, including SGLT2 inhibition, along with beta blockade, MRA, mineralocorticoid receptor antagonists, and RAS inhibition with ARNI in NYHA class 2 to 3, or ACE and ARB in NYHA class 2 to 4 heart failure patients as step 1. After optimization of these therapies, if patients remain symptomatic, hydralazine nitrates are indicated in African American or Black patients, and device therapies such as ICD and CRT are to be considered. Once guideline-directed therapy is optimized, other additional therapies such as ivabradine can be considered as a class 2A, very ciguat, digoxin, polyunsaturated fatty acids, and potassium binders in patients with hyperkalemia while taking RAS inhibition as class 2B indications. Additionally, surgical revascularization is indicated among patients, select patients with suitable coronary anatomy and ischemic cardiomyopathy, and transcatheter edge-to-edge mitral valve repair can be considered among patients with secondary MR, suitable anatomy, PA pressures, and ventricular size specifications after optimization of guideline-directed therapies. Wireless monitoring of PA pressure by implanted hemodynamic monitoring has a class 2B recommendation in our guidelines. In patients with heart failure with mildly reduced ejection fraction, SGLT2 inhibitors now have a class 2A recommendation, whereas ACE inhibitors, ARBs, ARNI, MRA, and beta blockers have class 2B recommendations. In patients with heart failure with preserved ejection fraction, SGLT2 inhibitors again have a class 2A, whereas ARNI, MRA, ARB have class 2B recommendations. Keep in mind, beta blockers are not included in the recommendations for patients with heart failure with preserved EF. In heart failure with improved EF after treatment, guideline-directed therapies should be continued to prevent relapse of heart failure and LV dysfunction, even in patients who may become asymptomatic. In patients hospitalized with heart failure, we emphasize decongestion and continuation and optimization of guideline-directed therapies. And very importantly, guideline-directed therapies should not be routinely discontinued or held in patients experiencing mild decline in their renal function or asymptomatic reduction in blood pressure during heart failure hospitalization. If it is truly necessary to discontinue, GDMT should be reinitiated and further optimized during hospitalization as soon as possible. Initiation of GDMT is a class 1 indication during hospitalization after clinical stability is achieved. We also have recommendations for cardiogenic shock, which include consideration of temporary mechanical circulatory support, management by a multidisciplinary team, placement of a PA catheter to define hemodynamic subsets, and consideration of triage to centers that can provide temporary MCAs for patients who are not rapidly responding to initial shock measures. Similar to the universal definition of heart failure, the stages of heart failure are revised and defined as at risk for heart failure for stage A, defined as patients at risk for heart failure but without current or prior symptoms or signs of heart failure, also without structural, functional, or biomarker cardiac abnormality. Pre-heart failure for stage B, for patients without current or prior symptoms and or signs, but with either structural or functional cardiac abnormality or elevated natriuretic peptide levels or elevated cardiac troponin, especially in the context of exposure to cardiotoxins. Heart failure for stage C and advanced heart failure for stage D patients. There are specific recommendations for these pre-heart failure stages of stages A and B, including a class 1 recommendation with SGLT2 inhibition for patients with type 2 diabetes and cardiovascular disease risk or cardiovascular disease to reduce heart failure events. And we also have a class 2A recommendation for natriuretic peptide-based screening in patients that are at risk, along with optimal control of blood pressure in hypertension, optimal management of cardiovascular disease, genetic screening and counseling in patients and families with genetic or inherited cardiomyopathies, multidisciplinary evaluation for patients with exposure to cardiotoxic agents, and lifestyle modification for all patients at risk for heart failure through the continuum. We also have specific recommendations for comorbidities, including class 1 recommendations for optimal treatment of hypertension in patients with heart failure according to guidelines, SGLT2 inhibitors in patients with diabetes, and a class 2A recommendation for IV iron replacement therapy in patients with iron deficiency, AFib ablation in patients with heart failure, and symptoms attributable to atrial fibrillation. We have a diagnostic and treatment algorithm for cardiac amyloidosis, which entails checking of monoclonal light chains, and if negative, technetium pyrophosphate scintigraphy. And in patients for whom the transthyretin cardiac amyloidosis is made, genetic testing with TTR gene sequencing, and recommendation for tetramer stabilization therapy in patients with ATTR cardiac amyloidosis. In patients with cardiovascular risk factors and cardiac disease being considered for cardiotoxic anti-cancer therapies, we do have recommendations for baseline evaluation and monitoring of cardiac function as Class 2A recommendation, and serial measurement of cardiac troponin as Class 2B recommendations. We also have specific recommendations for heart failure and pregnancy, including patient-centered counseling, Class 2A recommendation for anticoagulation for peripartum cardiomyopathy, and Class 3 or potential harm with ACE inhibitors, ARBs, ARNI, MRA, and SGLT2 in women with heart failure who are pregnant or planning for pregnancy. We finally have recommendations for vulnerable patient populations at risk for health disparities. In these patients, heart failure risk assessments and multidisciplinary management strategies should target both known risks for cardiovascular disease and social determinants of health as a means towards elimination of disparate heart failure outcomes. And evidence of health disparities should be monitored and addressed at the clinical practice as well as health system level. So this recommendation is not only for clinicians, but also for health systems. So in summary, we do have strong recommendations for quadruple therapy for all patients with heart failure with reduced EF, including SGLT2 inhibition, RAS inhibition, mineralocorticoid receptor antagonist, and beta blockade. For heart failure with mildly reduced EF, SGLT2 inhibitors, a Class 2A recommendation, whereas beta blockers, ARNI, ACE inhibitors, ARBs, MRAs as Class 2B recommendations. In heart failure with preserved EF, SGLT2 inhibition again has a Class 2A recommendation, whereas MRA, ARB, and ARNI Class 2B recommendations. And improved EF should be continued on guideline-directed therapies to prevent relapse. So with that, I would like to thank you for giving me the opportunity to present the heart failure guidelines.
Thank you so much, Dr. Boscard. That was a fantastic summary of the guidelines. Thank you so much for all the work that you put into that. I know how much work that requires, and it's a lot of dedication. And I know you love this topic. So thank you for all that great work. Our next speaker is Dr. Henry Huang, who is near and dear to me. He works with me at Rush University Medical Center. He is the editor-in-chief of the Journal of Interventional Cardiac Electrophysiology. He is the clinical director of the Complex Ablation Program and the director of the Cardiac EP Fellowship Program and associate professor at Rush University Medical Center. Henry, thank you so much for being here today. He will present the arrhythmia trials.
Thank you so much. And I'm a former Baylor College of Medicine alum as well. So thank you, Alex and Annabelle, for this opportunity to be here today to present the major updates for the scientific sessions from the arrhythmia corner. There were 5 late breakers that were presented, but in interest of time, I will present 3 studies. The first study that we'll talk about is the Pacific AF study. It was presented by John Piccini from Duke University, and its hypothesis was that based on preclinical testing and observational data from patients with factor XI deficiency, treatment with a drug called asundexian would have lower bleeding than apixaban in a cohort of patients with atrial fibrillation. The trial was randomized, double-blinded, phase 2 dose-finding study comparing asundexian at 20 milligrams or 50 milligrams with Eliquis full dose 5 milligrams BID in patients who are 45 years or older with atrial fibrillation, CHA2DS2-VASc score of 2 for males or 3 for women, and increased bleeding risk. The study was a multi-center study enrolling 755 patients in 14 countries in the US, Europe, and Asia who were randomly assigned in 1-to-1 fashion to either 20 milligrams or 50 milligrams asundexian or Eliquis 5 milligrams BID. Masking was achieved using a double dummy design with participants receiving both the assigned treatment and a placebo that resembled the non-assigned treatment. The primary endpoint of Pacific AF was a composite of major or clinically relevant non-major bleeding as per International Society of Thrombosis and Hemostasis criteria. In the cohort population, the average age was 74 years. 41% of patients were women. 29% of patients had CKD, and the CHADS VAS score was relatively high at 3.9. The ratios of incidence of major events versus apixaban were significantly lower with asundexian 50 milligrams and pooled together the 20 and 50 milligram dose patient cohort versus apixaban. The incidence of the primary endpoint was lower for asundexian 20 milligrams, but did not cross unity. Overall, according to the study summary, it was thought that asundexian was clinically equivalent, but with lower bleeding risk than Eliquis. So the question is for this drug, with eventually other NOACs become generic, is there a role for this drug? Perhaps I think with always less bleeding is something that would be a benefit to our patients. Another late breaker was titled simply Residual Leaks Post Left Atrial Appendage Occlusion. In this study of data from 51,000 patients in the NCDR registry with first generation Watchman devices implanted between 2016 to 19, they were retrospectively analyzed to assess for the correlation between peri-device leak size and the incidence of stroke and other outcomes. Patients were broken up into 3 categories: absence of leak, leak 0 to 5 millimeters or greater than 5 millimeters, which comprised 73%, 26%, and under 1% of the cohort respectively. And follow-up data was available at 45 days, 6 months, and 1 year. The primary endpoint of this retrospective study was composite of stroke, TIA, or systemic embolization. In terms of baseline characteristics, patients with large leaks had higher proportions of persistent AF, cardiomyopathy, and overall larger left atrial appendage orifice dimensions. A high proportion of patients with large leaks remained on oral anticoagulation at 6 months and 1 year. And again, this is a real-world study. Compared to patients with no leaks, those with leaks between 0 to 5 millimeters had higher risk of the primary endpoint at 1 year. However, while statistically significant, the effect size was small with a hazard ratio of just 1.15. So the large pool or number of patients may have contributed to the statistical difference. There were no significant differences comparing other groups. As for the secondary endpoints, patients with smaller leaks had slightly higher risk of bleeding events, again with an effect size that was relatively small and hazard ratio of just 1.1. And there was no significant difference in the use of oral anticoagulation at 1 year. Importantly, because of its design, the study had several limitations, being retrospective, although it's a real-world study with appropriate sort of selection bias in treatments. Imaging for leak size in the NCDR registry, at least what was recorded, was uncommon at 45 days. And so there was some incompleteness of data. Also, data on interventional leak management, such as coils and plugs, were not reported. And overall, the follow-up was just intermediate at 1 year at most. The final study, which is dear to my heart, are the results of the Partita trial. Does timing of VT ablation affect prognosis in patients with ICDs? This was a multi-centered study in Europe. The Partita trial was a 2-phase prospective clinical trial. In the first phase, patients with ischemic or non-ischemic dilated cardiomyopathy and ICDs placed for primary or secondary prevention were first enrolled into an observational phase until their first appropriate shock. Once a patient was shocked, they were approached, and then they were randomly assigned in 1-to-1 fashion to catheter ablation or conventional therapy within 2 months of their shock. The study's primary endpoint was a composite of all-cause mortality or hospitalizations for heart failure. Antiarrhythmic drugs were allowed, but amiodarone could only be given if the patient had documented concurrent atrial arrhythmias. In the end, the second phase of the trial was actually interrupted after the results demonstrated overwhelming superiority of catheter ablation in the first interim analysis. In the study, 517 patients were enrolled into the first observational phase. Over a median follow-up of 2.4 years, 30% of patients in the cohort had VT, with 11% receiving an appropriate shock. 47 of 56 patients, roughly 84%, agreed to participate in the second phase of the trial if eligible after shock. After 24 months, the primary endpoint occurred in 4 patients in the catheter ablation group compared to 42 patients at the control group. The results met the pre-specified termination criteria of greater than 99% Bayesian posterior probability of superiority of the catheter ablation over standard therapy. Mortality for catheter ablation was 0% versus 3% of the control group. And 4% of patients in the ablation group were admitted for heart failure, were hospitalized for heart failure versus 17% in the control group. Overall, ICD shocks were lower in the ablation group at 9% versus 42% of the control group. And as a result, the authors summarized that VT ablation after first shock was associated with lower risk of death and worsening heart failure, lower mortality, and fewer shocks. And so, very interesting study. And thank you again for the opportunity to be able to present these 3 studies.
Oh, thank you. Great study summaries. Thank you so much, Dr. Huang. Alex, do you want to take over and ask the questions that are in the chat box or in the Q&A? There are several that I see.
Sure. First of all, I would like to thank to all the brilliant speakers and co-moderators for having the time, for taking the time to do this. You all presented very important information, and I certainly learned a lot. I would have 2 questions for Biykem. Would you have any comments regarding, are there any differences between the recent American guidelines and the European guidelines on heart failure? Or maybe some huge or no difference between them?
We are harmonized. There are, I would say, minor differences. Our perhaps conceptualization of the stages of heart failure is quite distinct and different. So the terminology of pre-heart failure and the definition of pre-heart failure now entailing biomarkers is unique. It's harmonized with the universal definition that I have led, so that's one. Second, as you remember, the ESC guidelines were published a few hours after the Emperor preserved and did not entail SGLT2 inhibition as recommendations for heart failure with preserved EF or mildly reduced EF, and that's a significant distinction. In our guidelines, we also, in the aftermath of the LIFE-HF trial, specified ARNI indications for NYHA class 2 and 3 and not 4, though that is harmonized with their findings. Other concepts are ICD for us, for individuals even asymptomatic with cardiomyopathy with EF less than 35% is still a class 1 indication, whereas in the ST guidelines, in the non-ischemic cardiomyopathy, that was reduced down to a 2A. We did take a variety of other evidence into consideration and did not feel compelled to have to change the existing recommendations for ICD or CRT. And the rest are very minor differences. Overall, our approaches to comorbidities are very similar. We also have very distinct specific sections for cardio-oncology, amyloidosis, and pregnancy and vulnerable populations, including social determinants of health and health disparities in our guidelines.
Thank you so much. One short question with maybe, I don't know if that would be a short answer. I recently read a study regarding diagnosis of heart failure with preserved ejection fraction, invasive measurements by foot elevation. Would you think this is a promising thing to do for further better diagnosing the preserved ejection fraction heart failure?
Important feature of a diagnostic strategy in HFpEF, which requires maneuvers, and maneuvers can vary. And that can range from volume challenge to exercise, which is the common feature of the symptomatology. It's usually exertional angina, or in the hemodynamic assessment in the cath lab, especially doing a spine bike and or leg elevation or volume challenges. I think all of the above, and depends on the center and institution, and of course the patient variables. And keep in mind lack thereof, meaning lack of not seeing the natriuretic peptide elevation and or the increased filling pressures at rest is not an exclusion of a HFpEF diagnosis, and thus eliciting these and or unmasking these with exertion and or with maneuvers is helpful. That is included in the emphasis of elevated filling pressures either at rest or with provocation. So with provocation, I think, is the key. And I think there's another question about whether differences between mildly reduced and PEF. The EF is the cutoff, but the mildly reduced EF usually is a mixed batch of patients that are either changing dynamically from PEF down to reduced EF, maybe with a trajectory, because mildly reduced is dynamically changing, or individuals who are going in the improvement trajectory. So, and also it could be the restrictive cardiomyopathies, which may have specific treatment approaches. Beta blockers are not indicated in PEF for heart failure indication, but we do recognize a lot of HFpEF patients actually are on beta blockers due to a variety of other indications, be it CAD and or blood pressure management, and thus we recognize that they're commonly used. ACE inhibitors are ACE inhibitors can be indicated in the setting of CAD, again, another competing diagnosis. But for HFpEF indication alone itself, there are no specific recommendations for beta blockers and or ACE inhibitors. It's usually ARNI, MRA, and ARB, and SGLT2 inhibitors.
Thank you so much, Biykem. Two questions for Professor Roxana Mehran. So we presented a study with drug-eluted balloons. I recall reading a paper, recent paper a few weeks ago in JACC, stating that maybe drug-eluting balloons in de novo coronary arteries, maybe they are not so bad, even though the comparison was between two drug-eluting balloons. Would you say this is an interesting idea to follow up, or maybe the science behind the drug-eluting balloons will further evolve in order not to put any material into the arteries?
Yeah, so thank you for bringing up that question, because in my mind, I believe that is one of the negatives for us in the United States, not having drug-coated balloons available to us. And I mean, you know, when you think about small vessel diffuse disease, in-stent restenosis, bifurcation disease, where instead of putting more metal, we can at least give the artery a chance with delivering some drug to the vessel wall through using the balloon, drug-coated balloons, we can have really, really good results. And the results seem to be okay in albeit small studies, but we really, really would like to see this device be made available in the coronary side. But it, as you know, they have to go through the FDA regulations, and there are several trials now, and we're hoping that we're going to see hopefully this device become available in the United States as well. But it is widely available outside of the US, and I think that they enjoy the benefit there. We have several patients with multiple episodes of in-stent restenosis, and really, I mean, intravascular brachytherapy should be the last resort, and yet we're seeing that in some cases we have to do this because we don't have drug-coated balloons. So it's a really good question and an important one.
Thank you so much, Roxana. So we're using it in France, especially, as you know, for lesions for small vessels or for intrastent restenosis. But maybe this would be an interesting path to see where it goes. One more question. What would you think is the highlight of the interventional cardiology studies presented at the ACC?
No, I mean, I think that, you know, the trial that really got my attention, I think we're now on the coronary side are working very, very hard to enhance and improve our outcomes even better. And so physiology and IBIS guided, you know, technologies employed and guiding us in PCI is tremendously important. So I really like the FLAVOR trial. On the TAVR and structural side, we saw the 5-year data from Surtavi with really good hemodynamic results compared to surgery for the TAVR valves. So it's basically telling us that, you know, the TAVR devices are doing extremely well. It should probably be associated with even better and enhanced durability. And that as well is a fantastic piece of news. I think those were the two most important. And then opening the window, and I'm not sure that it's the door, but it definitely is opening the window on renal denervation. And I didn't include those because I was supposed to talk about ischemia studies and coronary, but renal denervation, the durability and some of those long-term results that was presented at ACC is also extremely encouraging for us to think about what else can we do in enhancing treatment of hypertension in those who are already on meds, that the adjunct treatment with renal denervation could actually keep them on those medicines without having to add more and having less hypertensive episodes. So all of that was very, very positive. And I think those were the three areas that I would pay a lot of attention to in the future.
Thank you so much, Professor Mehran. Annabelle?
Yeah, I have a question for you, Roxana. In the flavor study, did they look at sex differences in that?
No, they haven't, but I'm sure it will be coming. And I also would love to see the post-PCI use of FFR versus IBIS. That evaluation is also really interesting. And so it'll be really exciting to see more of these data presented at other meetings, 1,700 patients, lots of patients.
That'll be very interesting. Thank you. Dr. Lundberg, there was a study that looked at whether we should be treating pregnant women more aggressively for high blood pressure. Can you talk about that a little bit?
Yes, that was the CHAPS study. And it's really very important because for several years, cardiologists have felt that lower blood pressure under 130/80, even 120/80 is optimal, while our OBGYN colleagues have been fearful that this would have negative effects on the woman, the placenta, or the fetus. And so CHAPS really kind of answered that. It's a nice large study of over 2,400 women, 1,200 were assigned to the more aggressive treatment goal of less than 140/80, and the others were in the traditional role of blood pressure less than 160/90. The drugs that were primarily used were labetalol and nifedipine, and they looked at these two different treatment groups for any adverse outcomes for maternal mortality. There was no difference. But when it came to terms of preeclampsia and preterm delivery, they saw a big improvement in the lower blood pressure group. 24% had preterm labor or preeclampsia, whereas in the traditional treatment, it was 31%. So very nice studies showing the safety and the benefits for women to have lower blood pressure during pregnancy.
Alex, do you have any other questions from the audience? You're muted.
Sorry for that. No, not for the moment. So maybe we should ask Henry what were the highlights of the ACC?
Thank you so much. I think, having another alternative vitamin K, non-vitamin K antagonist, is a good issue. Our drugs are good, but, we still run into, issues, particularly post-procedure after an ablation, or even after a Watchman device. How do we properly anticoagulate these patients that are having these appendage closure devices as secondary prevention after bleeding? It becomes sort of a sticky issue, and dose reduction, of these drugs might lower bleeding, but you worry sort of about the, how protective it is for DRT. And so having a drug potentially that is effective yet has a lower risk of bleeding, I do think there is a place for that. And, that is a major contributor to non-compliance for the NOACs or DOACs, so to speak. Whether that will justify the added cost of a newer drug, once Xarelto and apixaban become generic, that will be the question, but I do think there is a place. I thought the Partida trial, was very interesting. It was in Europe, and at least in our field, there are many different ways sort of you can do an ablation and approaches. And it's always nice to see in a large patient population that a treatment strategy, across a broad array with strict treatment criteria has such a strong sort of positive effect. It is
Henry, can I just ask you, was that a heterogeneous group of patients? Was it, I'm sure it was not ARVD, VT ablation. Was it mostly ischemic induced ablation, or was it LV VT. Can you talk about the patient population?
Right. So South American patients were not included. So there was not Chagas disease, which would be primarily epicardial. There were ischemic and dilated non-ischemic patients. The paper actually recently came out, and I'll have to see if area VC was excluded. But the most heterogeneous thing, and it was a randomized study, so the baseline characteristics should be roughly similar. What was the heterogeneity is that some of the patients were primary prevention, and some were secondary prevention patients. And so the risk of, recurrent VT, is higher in a secondary prevention patient, and probably mortality. And I think what we're seeing here is that this is a situation where the sickest patients benefit the most from the treatment. And so that's why you're seeing such a large effect. Now, I think, not every center has the ability to do complex VT ablations. And remember, this is a very sort of aggressive strategy. You're referring patients after a first shock, to an ablation within 2 months. And so it depends on how well centers are prepared. This may steer a bit toward, referring to experienced centers, but it suggests that patients do benefit. What it suggests actually is that patients have high mortality and high CV morbidity if they are treated just with medical therapy after shock. It's not a great sign. And perhaps ablation may help these patients, at least for the short term.
Thank you. One last question for Biykem and Gina. What should we tell our patients about salt intake for hypertension and heart failure?
All right, I'm going to go first because I'm very skeptical about this study. I want to hear more details. I want to hear how it was designed, because it just feels like for 30 years clinically, I've seen sodium be a real problem in the South after, Easter and Thanksgiving with all the fried foods and the high salt foods. The ERs are full of heart failure patients. So I'm just a little hesitant to jump on that you don't have to worry about salt bandwagon. I can't wait to hear what Biykem says.
Thank you for that introduction, Gina, because that's the crux of the matter. This study actually was designed with good intentions. The enrollment baseline sodium intake was 2,200 milligrams. So keep in mind, in the US, the average salt intake is about 6 grams. So at the get-go, the trial inclusion included individuals with what we would consider or lower than the general population sodium intake. And this was a lengthy study with 12 months of adherence to a salt reduction by menu prescriptions that are given by dietitian as alternative strategy. So you can imagine how difficult it is, one, to change one's diet. And at the end of the study, I just recall in a survey, that's how they attested to the salt reduction. These were not urinary sodium measurements. Individuals, when they reported how much salt they reduced, which usually is over-reported, right? Because individuals want to really demonstrate their compliance, and this was not a blinded study. The decline from the control group was only 415 milligrams, meaning very small amount of a reduction, if at all. So thus, the NYHA class and the quality of life measures are very, of course, promising, but the lack of the hospitalization and all-cause mortality and cardiovascular death, which is the endpoints that the investigators elected, the study was not powered to be able to detect that difference with this much of a little difference in an individual that is already with a rather low sodium intake. So in essence, these individuals were not with large sodium intake and were not individuals with significant hyponatremia, which actually were an exclusion criteria, as well as advanced CKD, which is the group of individuals that we struggle with in terms of decongestion strategies. And thus, I would not assume the negative results of clinical endpoints here should not be a signal to change our practice. I don't think the study is informing us to change our practice one way or the other.
Thank you so much, Biykem. Thank you, Gina. So we are approaching the end of our webinar. I would just like to ask Professor Volgman and my co-host, which I have the pleasure to do so many webinars. Annabelle, what would be your intake on the ACC Congress? Do you have any favorite study, or maybe some personal information or thoughts?
Thank you so much for that question. I don't have a favorite study. I think that what was the most remarkable about the ACC was that it was the first major conference that we've had since the COVID pandemic, and that we all loved being together. And so I don't think the live conferences are dead. I think they're very much alive, and we look forward to more of these as we have before. I think we took a pause during the pandemic, and we learned a lot, and we can continue to do a lot of Zoom meetings, but there is nothing better than being together to learn together. And also the networking and the camaraderie was really the best part of it.
I fully agree. I think all of us agree with you. So I think we have to end our webinar. Thank you so much to all the speakers. I'm sure everybody learned a lot. I especially learned a lot. Thank you so much once again, and I hope to see you soon, either on a very beautiful webinar or in a live congress. So thank you so much for your precious time, and I hope to see you soon. Thank you.
Thank you.